So good morning, everyone from Kensington. Thank you all very much for tuning into Zoom today. My name is Katie Anker, and I'm an R4 in the Adult Emergency Medicine Program, as well as a first-year Pediatric Emergency Medicine Fellow. Today, I'll be discussing the life-threatening diagnosis of pediatric myocarditis and how the troponin can aid you in making this frightening, fascinating, and often elusive diagnosis in the emergency department. I'd like to personally thank Dr. Lawrence de Koning, a clinical biochemist that runs the Alberta Precision Lab at the Alberta Children's Hospital, who's kind enough to discuss the murky waters of troponin assays with me and is on the call today. I'd like to thank several members of the ACH cardiology department who are also kind enough to answer my cardiac-related questions. Aaron Peterson, who is our PLP mastermind that has set up these rounds, and Dr. Jennifer Graham, one of our own ACH emergency medicine doctors, who will be moderating our discussion. If you have any questions, please type them in the question and answer section. You can upvote questions that you also have, and then we'll discuss them at the end. I have no financial disclosures, but I would like to disclose that, like many pursuits in life, my pursuit and desire to learn about this topic was largely out of blend of fascination and anxiety. I am as equally as intrigued by the underlying pathophysiology of myocarditis as I am concerned I'm going to miss it among the sea of fevers that I see every shift at the Children's Hospital. Myocarditis is rare. It's estimated to only account for 0.05% of admissions to peds tertiary care hospitals. However, this data likely underestimates the true incidence of myocarditis, as patients may have subclinical disease or not be appropriately diagnosed. It's dangerous. Mortality is rated between 4 and 10%. Morbidity is also substantial. In a recent American pediatric database, 18.9% of patients diagnosed with myocarditis required ECMO, and 8% required a ventricular assist device or cardiac transplant. The AHA ranks myocarditis as the third leading cause of sudden cardiac death in children, after HOCM and coronary artery pathology. The clinical presentation and spectrum of disease is variable, often with nonspecific and subtle signs fraught with uncertainty, from symptoms as vague as abdominal pain to subtle arrhythmias to cardiogenic shock. Multiple retrospective reviews have identified that 60 to 80% of patients with myocarditis were not diagnosed on their first visit to emerge. Diagnostic criteria is continually evolving. The traditional gold standard is an endomyocardial biopsy, which is invasive and can miss focal disease. At many centers, including the Children's Hospital, this is rarely done unless there is persistent diagnostic uncertainty. Lastly, the data surrounding the diagnostic accuracy of troponin and myocarditis is quite muddy. Today, we're going to arm ourselves with knowledge to take on two of these challenges that we can face in the emergency department: how these children present to the hospital and helpful tests to make the diagnosis, including troponin. I will first briefly discuss the pathophysiology and phases of myocarditis. Then we'll explore the clinical presentations and which investigations actually help in identifying these patients. We'll then take a deeper dive into the troponin literature in pediatrics, and then give a new update to how stat troponins will be run at the Children's Hospital. Over 50% of pediatric myocarditis in North America and Western Europe are caused by cardiotrophic viruses. This disease progresses through three distinct phases based on animal studies of viral myocarditis. Over the last 20 years, there has been an epidemiologic shift of causative agents, with entero and adenoviruses being more common prior to 2000, and parvoviruses, herpes viruses, and EBV being much more common now. Locally at the Children's Hospital, we've had a handful of influenza-induced myocarditis. Other infectious etiologies also can occur, including bacterial, fungal, parasitic, and protozoal. This model has been adapted for non-infectious precipitants as well. Drug reactions, hypersensitivity reactions can cause myocarditis. Although we predominantly think about the dreaded coronary artery aneurysms and Kawasaki's disease, the majority of patients also have some sort of myocarditis, even though this might be subclinical. The first phase of myocarditis occurs anywhere from a few days to a few weeks after the start of infectious symptoms and only lasts about a week. viruses enter the myocytes, replicate, and cause necrosis. This releases cytokines and chemokines and exposes normally hidden cellular antigens. This in turn activates our immune system, which in turn causes further damage. Again, this phase only lasts a few days. Patients may or may not be symptomatic. Separated from classic acute myocarditis is a distinct and dangerous entity called acute fulminant myocarditis. This is characterized by sudden onset left ventricular systolic dysfunction that manifests in cardiogenic shock, arrhythmias, and congestive heart failure in a previously healthy patient. There's usually a history of an antecedent viral infection, and by definition requires aggressive inotropic support, with some patients going on to need a ventricular assist device, ECMO, or even transplant. This is more commonly seen in infants. In adults, patients with fulminant myocarditis paradoxically do better than patients with acute myocarditis, with often complete normalization of their left ventricle. However, the literature in children with fulminant myocarditis is less consistent, with mortality ranging from 9 to a whopping 48%. Back to the phases of myocarditis. After the acute viral-induced myocyte destruction of phase 1, some patients may recover. In some, ongoing autoimmune reactions occur, driven by T cells inappropriately targeting patients' myocytes, as well as ongoing cytokine storm. This phase can last weeks to months and often manifests in heart failure. For the majority of patients, this leads to recovery, where the initial pathogen is usually cleared, the immune reaction settles, and the left ventricular function returns to normal. However, the autoimmune destruction may continue on in subtle and often subclinical ways, leading to ongoing undetected myocyte damage in this third phase. Up to 30% of patients with myocarditis may progress to dilated cardiomyopathy, which is associated with very poor prognosis. Knowing this, how do we identify these patients so our inpatient cardiology and PICU colleagues can optimize their treatment? Prior to this talk, I thought about myocarditis like this. In and amongst the sea of sick, febrile children is one with cardiotropic virus that is silently waiting to wreak havoc on their myocytes, and I might miss it, a proverbial needle in the haystack. But perhaps a more pediatric and quarantine-appropriate analogy would be of this: Waldo. When you play Waldo, either by yourself or with your children, do you scan the page randomly, or do you have a systematic approach? Ben Blatt, a journalist from Slate, sought to identify if there was in fact a pattern to where Waldo is located, without any qualms of appearing ridiculous in public. And in pre-COVID era, he sat in Barnes & Noble for 3 hours with 7 Where's Waldo books and a tape measure. Each dot on the screen represents one of the locations Waldo was. As you can see, in over 50% of the time, Waldo is located in 2 discrete bands. Can we do the same thing with myocarditis? Literature surrounding the initial emergency department presentation of pediatric myocarditis consists of case reports, series, and small retrospective trials. I have collated 8 studies that specifically identified presenting symptoms and signs of patients that went to be diagnosed with myocarditis. 4 are in the States, totaling 350 patients in total. There is one excellent Canadian study from our very own Dr. Friedman and Dr. Toole Friedman out of Toronto that included 31 patients. There was one large database study out of Germany that described very basic presenting features, and 2 smaller retrospective studies out of Taiwan and Singapore. All in all, that's 642 patients. So what did they find? 4 studies presented here provided ages of children diagnosed with myocarditis. There is a clear bimodal age of distribution, with increased prevalence in infants and toddlers, and then increased in teenage years. A few studies also mentioned gender discrepancy, with more males than females being diagnosed. This is the collected data from the mentioned studies. I broke the signs and symptoms down by system, which a few of the papers did, into respiratory, cardiac, hypoperfusion states, and GI. This is cumbersome to look at and commits many PowerPoint sins, so let's try to pare this down. First, cardiac symptoms. Chest pain was present anywhere from 19 to 74% of patients. 2 of the studies split these patients down into 2 age groups, one younger and older than 6, and one younger and older than 10. The younger children were far less likely to present with chest pain, which if you spend any time with children, you can understand why, whereas patients older than 10 were far more likely to. Tachycardia was only present in 30 to 60% of the patients, which was surprising. Hepatomegaly was documented in up to 50% of these children, which highlights the importance of a full cardiac exam, including peripheral pulses, perfusion, and hepatomegaly. In 6 of the studies, the most common presenting complaint was shortness of breath, work of breathing, being present in up to 69% of children. Rhinorrhea and cough was present concomitantly in 33 to 43% of patients. Paired with this shortness of breath was tachypnea, occurring in 58 to 68% of patients. Lethargy was a common finding in up to 62% of patients, with syncope and seizures occurring anywhere from 8 to 46%. Lastly, GI symptoms, which we often forget about, including nausea, vomiting, abdominal pain, diarrhea, occurred anywhere from 7 to 59%. So let's summarize. Age of presentation is bimodal, occurring more commonly in infants and then again in teenage years. Symptoms and signs are varied. The most common presenting complaint in a younger population is shortness of breath, whereas in the teenage population is more likely to present with chest pain or abdominal pain. The most important thing to do is have a high degree of suspicion for this diagnosis, especially with unexplained vital signs. Know that this can also happen with normal vital signs. Moving on to investigations. The European Society of Cardiology identified that the ECG is the single most useful screening test in myocarditis. It is surprisingly abnormal in 87 to 100% of patients, with findings including ST changes, T-wave abnormalities, axis deviation, AV blocks, arrhythmias, and low voltage. Findings are not necessarily specific, and I would argue that if your clinical suspicion is high enough, an ECG should not be used alone to rule out myocarditis. Let's meet our first patient, Matt. All of the patients that I'm presenting today are real cases that have happened at the Children's Hospital in the last 6 months. I've obviously changed their names and I'm using stock photos as I don't take photos of my patients. Matt is a 14-year-old that presented to the emergency department 3 times. On the first visit, let's say on day 1, he presented with 3 episodes of diarrhea over the last 24 hours and abdominal pain, with no nausea, vomiting, fever, or chills. He had normal vital signs with no alarm features. He was sent home appropriately with an outpatient stool kit, a prescription for Pantaloc, and asked to follow up with his GP return if he was worsening. 2 days later, he represented to a different Calgary emergency department with ongoing epigastric and now centralized chest pain. He stated it was non-palpable, radiating to the jaw and arms, and associated with shortness of breath. He had no persistent infectious symptoms, no exertional symptoms, no ingestions. An ECG was done that was normal. He was discharged home with ranitidine to be added to his Pantaloc. 2 days after that, he presented to the Alberta Children's Hospital Emergency Department with ongoing, now sharp chest pain that was refractory to both Pantaloc and ranitidine. It continued to radiate to his jaws and his shoulders bilaterally. He had no persistent nausea, vomiting, or diarrhea. Here is his ECG. As you can see, it's normal sinus rhythm with right axis deviation. He has no overt ST changes or T-wave abnormalities. However, if you look closely, he has 1 P wave here that is not conducted, so 1 beat of 2nd degree Mobitz type 2 heart block. Subtle. His chest x-ray was normal. A high sensitivity troponin was sent, which came back at 1962. D-dimer was also sent, which was normal. His echo was normal. He had normal anatomy, normal left ventricular and right ventricular ejection fraction, and no pericardial effusion. He was admitted to Teams on telemetry and proceeded to have 20 beats of non-sustained VTAC. He was therefore transferred into the ICU. In the ICU, he had several asymptomatic intermittent blocks, including 1st degree, 2nd degree Mobitz type 1, and bradycardia with rest, with heart rates going down to the 30s, but was surprisingly relatively asymptomatic throughout all of this. He was discharged home 6 days later on a beta blocker, with no participation in strenuous activity recommended. So in reflecting on this case, I don't think anything was necessarily missed with his presentation. I do think that this case, though, impresses the importance of really scrutinizing the ECG and looking for subtle findings like AV blocks or ST or T wave changes or axis deviation. It also highlights having a higher degree of suspicion in patients presenting multiple times. What's interesting is that even though his echo was structurally normal, he did have conduction delay, highlighting that an echocardiogram isn't 100% sensitive for myocarditis. A chest x-ray is a fast, simple, and normally clinically indicated anyways, as these patients have shortness of breath. It is abnormal in 55 to 90% of patients, so less sensitive than the ECG, and they should be used concomitantly. The most common findings are cardiomegaly, pulmonary edema, and pleural effusions. Not surprisingly, white blood cell count was only elevated in 27% of these patients. CRP was only elevated about half the time. Therefore, these both aren't particularly sensitive or specific tests, but they can help us distinguish underlying inflammatory conditions. A venous gas can be very helpful at assessing end organ perfusion with a lactate. Culture should be done as clinically necessary. BNPs are not routinely recommended in the emergency department, but are often used by our inpatient colleagues to help demarcate this disease. Let's meet another patient. Penelope is a 14-month-old female that was seen at the emergency department about 2 months ago in the morning. She presented with lethargy and increased work of breathing for 24 hours, with no fever, no cough, cold, runny nose, sore throat, no nausea, vomiting, or diarrhea. She was previously healthy, with potentially a history of reactive airway disease, was on a puffer that she didn't use. She had no sick contacts, no travel. Her immunizations were up to date. On exam, she was afebrile, tachycardic at 167, but she was crying, tachypnic at 68, and hypoglycemic at 3.4. She had a normal respiratory, cardiac, and abdominal exam. She was treated with IV D5-NS. This is her chest x-ray. It was interpreted by the emergency physician as a right middle lobe pneumonia. As it was during the day, the radiologist report came back pretty quickly and noted that the cardiac size appeared large, and there's areas of patchy consolidation on both the right and lower lobes. They included a differential diagnosis of interstitial edema versus multifocal pneumonia. This was discussed with cardiology over the phone, and they recommended sending an outpatient referral to them for the cardiomegaly. Good discharge instructions were given to return to the ED if worsenings, and the child was sent home with antibiotics. Unfortunately, our story doesn't end there. Penelope significantly declined over the day, had increased work of breathing, refusing oral intake, and becoming lethargic. She remained afebrile, but had worsening tachypnea and tachycardia. When she came in, she looked very unwell. Her gas showed a significant metabolic acidosis with a lactate of 10. Additionally, her high sensitivity troponin T was elevated at 114. A BNP was drawn, and it eventually came back, not in the emergency department, as sky high. She unfortunately further declined in the ED and was admitted to the PICU, where she had a stat echo done. Her echo showed severe left ventricular systolic dysfunction with an ejection fraction of 23% and a right ventricular ejection fraction of 25%, with normal coronary arteries and valves. She required high flow and Miller-Known support and went on to be intubated. She continued to decline in the PICU, and on day 3 of injury had developed acute liver failure secondary to ongoing ischemia from profound cardiogenic shock. She was cannulated for ECMO and transferred to Edmonton, where she was stabilized on VA ECMO for 10 days, then weaned off vasoactive medications. Almost a month after presentation, she was transferred back to the Children's Hospital and is now discharged into the community. Her last echo at the end of March shows persistent dilated cardiomyopathy, a dreaded complication, with a left ventricular ejection fraction of 33%. So my take home for Penelope's case is beware of the child with bilateral multifocal consolidations in the absence of any respiratory symptoms. If you're concerned at all about these patients, consider ordering an ECG, troponin, and gas. Also consider that if cardiac POCUS is in your armamentarium, then by all means, please use it. As you know, bedside ultrasound is not well studied in the pediatric population as it is in adults. However, it is particularly helpful to identify a pericardial effusion, evaluate general function, and potentially assess for pulmonary edema as well. If your suspicion is high, a formal echo should be obtained, which can assess the coronary arteries, valves, and anatomy, including ventricular function and any pericardial effusion. A big take home is to be aware of diagnosing the multifocal pneumonia in patients without any infectious symptoms, as this could be underlying pulmonary edema. ECG is a very good screening test. Make sure you scrutinize the details. If you're doing an ECG, consider doing a troponin and a chest x-ray with it. If you have POCUS skills, use them. Don't be afraid to use them just because it's a child in front of you. The anatomy is the same underneath the skin. And know that arrhythmias can occur in a patient even with a normal echo. So if there's a history of syncope or palpitations, consider telemetry monitoring for these patients. Putting this together, making the diagnosis requires maintaining a high degree of suspicion, especially in children under the age of 2 and in teenage years. Ensure that you can explain why your patient has abnormal vital signs, especially tachypnea and tachycardia. In younger children, think about it with GI and respiratory concerns. In teenagers, think about it with persistent chest and abdominal pain. If you are concerned, investigate with an ECG, chest x-ray, troponin, and a gas. Okay, so now is the time to take off your N95s, grab your snorkel, because we are taking a deep dive into troponins. First, let's cover some basics. Troponin is a regulatory protein complex involved in the contraction of skeletal and cardiac muscle. Each troponin complex is composed of 3 proteins, troponin C, T, and I. Both troponin T and I have cardiac-specific isoforms that are structurally different than their skeletal equivalent. Therefore, they have been utilized as an indicator of myocardial damage in testing. The first generation troponin I and T assays were released in the late 1980s. Since then, numerous companies have considerably optimized the detection, sensitivity, and specificity of these assays. Unfortunately, that means that it's often challenging to compare troponins. As a general rule, different troponin assays should not be compared to one another. The troponin assays that are currently available and most relevant to our Calgary emergency departments are the high sensitivity troponin T, which we use at the Foothills, the Rocky View, the Peter Lougheed, and the South Health campus, as well as we should be aware of the high sensitivity troponin I, which our urgent cares use. So why do we care about troponins? In the emergency care of adults, the high sensitivity troponin has revolutionized our ability to rule out and rule in acute myocardial infarction in the right clinical context. But what about in children? When it comes to troponin, unfortunately, children aren't just little adults. The water is a little bit murkier. The incidence of atherosclerotic coronary artery disease is far less common in the pediatric population, and therefore emergent treatment of acute myocardial infarction is not necessarily indicated in pediatrics. And I'll get to that about what troponin and ACH uses. So let's start with the basics. Is the cutoffs for pediatric troponin levels the same for adults? Surprisingly, the answer is no. The Caliper program took samples from 598 healthy patients and tested them for the highly sensitive troponin T that the Foothills uses. This 99% value represents the highest value that 99% of these children had less than, also known as the upper limit of normal. As you can see, there's markedly increased troponin in healthy children aged 0 to 6 months at 83, which then decreases to 19 from 6 to 12 months. This was a surprise for me. These little kids are not having acute MIs. We're not exactly sure why this is happening, but it's theorized to be from transient hypoxemia at birth or potentially fetal cardiac troponin, which is in skeletal muscle and cross-reacting with the assay. In children aged 1 to 19, the upper limit of normal was 6 for females and 6 for females and 11 for males. So we know what a normal troponin is and that coronary artery disease is uncommon in children. What causes a troponin to be elevated? In reviewing 6 retrospective reviews looking at all positive troponins that were ordered for any reason, excluding cardiac surgery and known congenital heart disease, these were the main causes. As you can imagine, the majority of positive cases were secondary to cardiac damage, with 21 to 79% occurring in myocarditis. Other common causes were pericarditis, anomalous coronary artery anatomy, including L kappa, and chest trauma being the most common. Non-cardiac causes are similar to adult population, including intoxication, sepsis, burns, and any sort of multi-organ failure sick patient. But how about troponin specifically in myocarditis? I will present 4 papers explaining this. Heavily cited is a paper in 1997 by Lohr and colleagues that included 80 adult patients with clinically suspected myocarditis, with 49 of them confirmed on biopsy. A cutoff of 0.1 nanograms per mil for the cardiac troponin was used. Keep in mind that this is the 2nd or 3rd generation of troponin T, and not nearly as sensitive as the assays that we use today, which is a 5th generation. This is entirely different. They found a sensitivity of 53% and specificity of 94%. So not great. In 2002, Song and colleagues included 43 patients with suspected myocarditis or dilated cardiomyopathy. Cutoff value for troponin T was 0.052, calculating a sensitivity of 75% and a specificity of 86%. So better than the Lohr study, but likely just because we were actually dropping the upper limit of normal as assays were becoming more sensitive. In 2012, Eisenberg and colleagues published a retrospective review of 221 pediatric patients that had troponins tested. Of the 221 patients included, 18 had myocarditis. When a cutoff level of 0.01% was used, or 0.01 nanograms per mil was used, the troponin was 100% sensitive, 85% specific, and had a negative predictive value of 100%. So we're moving in the right direction. This year, Malik and colleagues in Poland monitored 18 adolescent patients with acute myocarditis. Using a cutoff of 19, so a different assay, a high sensitivity troponin I was positive in 16 of 17 patients. So our new high sensitivity troponins are a sensitive marker of myocardial damage, but what about in other disease entities? Prior to diving into this talk, I perceived myocarditis and pericarditis as mostly 2 separate entities. I knew that they were both involved in badness of the heart and that they share a Rosen's chapter. In reviewing the literature, there's considerable blurring of these diagnoses, and they aren't necessarily 2 separate entities. The way in which our cardiologists demarcate this is depending on the dominant presentation. But this can be challenging because as we have discussed, myocarditis doesn't present in one classic way. Perimyocarditis is predominantly myocarditis with some pericardial involvement. These patients will have ECG changes, dysfunction on their echo, and high troponins. We will get to what is considered high. These patients will need to be admitted and followed very closely. Myopericarditis, on the other hand, is predominantly pericarditis. Patients present classically with chest pain, and the ECG features of pericarditis, ST elevation throughout leads, and PR depression. In discussion with Dr. Greenway, one of the ACH cardiologists, oftentimes this ST elevation is subtle and doesn't actually meet the 1 millimeter of diagnostic criteria as in adults. These patients will have minimally elevated troponins and no dysfunction on their echo. They are treated like pericarditis and usually sent home with NSAIDs, colchicine, pantoprazole, and potentially an echo as an outpatient. From the cardiologist, a high sensitivity troponin T level is high if it's over 100 nanograms per liter. They state that this is somewhat arbitrary, but indicates that there is significant myocardial involvement and earns you an MRI in the future, as well as exercise restriction guidelines. This comes as a surprise to many of our adult trained emergency physicians, as we can rule out or we can rule in an MI with a troponin of less than 100. However, it's important to note that these are different disease populations, and we cannot necessarily apply what we know in adults in acute myocardial infarction to myocarditis in children, a completely different disease process. Let's meet our last patient, Jeremy. Jeremy is a 16-year-old male that presented to a Calgary emergency department with 2 days of chest pain. The chest pain was constant, non-pleuritic, did not radiate, and was worse when lying down. It was associated with shortness of breath. 4 days prior to this chest pain, he had had a tactile fever and some very transient, self-resolving nausea, vomiting, and diarrhea. No rash, no red flag features, no recent travel or sick contacts. He was, however, diagnosed with schizophrenia 3 weeks earlier prior with visual and auditory hallucinations and was started on quetiapine. He denied any substance abuse, and he had normal vital signs as well as a normal cardiorespiratory and abdominal exam. This is Jeremy's initial ECG. I'll give you a moment to have a look at it. As you can see, he has high anterior lateral ST elevation, as well as reciprocal depression in the inferior leads. The physician at the adult site very appropriately gave Jeremy aspirin and was going to treat him as a STEMI. He then discussed this case, Jeremy's case, with the pediatric cardiologist on call, who recommended using NSAIDs, colchicine, and being treated for mild pericarditis. He then recommended transfer over to the Alberta Children's Hospital. His chest x-ray was normal, and he was transferred over. A high sensitivity troponin was drawn, which was 1400. His CRP was elevated at 17. So I looked after this patient briefly in the emergency department, and I have to be honest with you, his ECG made me nervous. He had ongoing chest pain in the ED. We did multiple repeat troponins, and they looked pretty similar to this. If I were at the foothills, I would have called the cath lab to ask for advice. But I was at the Children's Hospital, and so he was admitted to Teams. Overnight, he had ongoing chest pain. His ECG had improved, but cardiology did a stat echo because of concerns for his symptoms. It showed normal anatomy, borderline systolic dysfunction with no pericardial effusion, and a hypokinetic basal inferior left ventricle. Shortly thereafter, a cardiac MR was done, which showed hypokinesis in those same areas, as well as cardiac wall edema, making the diagnosis of focal myopericarditis. This was thought to be induced by quetiapine. MRI is identified to be a very sensitive test for demarcating ischemic patterns of cardiac damage versus myocarditis, which is usually indicative of myocardial edema. I had a discussion with this case with Dr. Greenway. He follows most of these pediatric patients with myocarditis as an outpatient. He said it was fair for us to be anxious. His colleague on call was also anxious about the ECG and did call the cath lab to discuss the case. There are case reports and small reviews that describe patients similar to Jeremy. They present with chest pain, sky-high troponins, and focal ECG changes, who in an adult, you wouldn't think twice about activating the cath lab. In all of these patients, if a cath was done, it did not identify any coronary artery thrombus. So where does that leave us? My take home from this case is that if you're worried, share your worry with your friends. Have a discussion with your cardiologist, who is definitely an expert in the field and can help demarcate the best treatment for these patients. So to summarize troponins, first, please know exactly what assay you're ordering. Secondly, don't compare between the assays. The high sensitivity troponin T is different than the high sensitivity troponin I that's done at our urgent care centers. High sensitivity troponin is going to be elevated in healthy children less than a year old. So please use discretion when interpreting these results. And lastly, from the literature that I've reviewed, I think the high sensitivity troponin is sensitive at detecting myocardial damage in myocarditis. I advocate for using the troponin as an adjunct to your clinical assessment, never using it in isolation. So let's bring this back locally. Currently, the Alberta Children's Hospital is the only hospital in the Calgary region without a high sensitivity troponin analyzer. So when a troponin is ordered at the Alberta Children's Hospital, it is actually ran here at the Foothills Hospital, which you can imagine often causes significant delay. Dr. Lawrence de Koning, a clinical biochemist and the head of the Alberta Precision Laboratories here at the Alberta Children's Hospital, has been working with the emergency department, cardiologist, inpatient services, and PICU, advocating for the ACH clinicians to have timely access to a troponin assay. He has very kindly shared the data on the following slides. I am in no way affiliated with the work that has been done, but am a conduit to this information. First off, how often is a troponin ordered at the Children's Hospital? Over a 2-year period that Dr. de Koning collected data, 692 high sensitivity troponins were ordered, which is approximately 1 per day. The emergency department ordered about half these cases. Let's look at the process for when a stat or time-sensitive troponin is ordered. First, it is collected from the patient and received at the ACH lab. It is then couriered to the Foothills lab where the sample is run. You can imagine that the rate-limiting step is transportation from the ACH to the Foothills Hospital. Dr. de Koning has already optimized this process in the last few years. He's done this by including collecting troponin assays in separate tubes so that they don't need to be aliquoted by the ACH lab, bypassing the batching process and dealing with them like stat labs, just like our trauma labs at the ACH, and prioritizing couriers to the Foothills Hospital. However, despite this tremendous effort, there have been concerns and several RLSs related to this delay, as these samples are often on high-risk pediatric patients, including patients with known Kawasaki's, congenital heart disease, and potentially patients in the emergency department with myocarditis. Currently, from the data he collected, about 21% of samples drawn at the Alberta Children's Hospital took more than 2 hours to come back. So ideally, an ideal solution would be to actually get the high sensitivity troponin T at the Alberta Children's Hospital. However, in this political climate, this unfortunately might not happen for a while. Dr. Lawrence de Koning and his lab have come up with this temporary solution to overcome this clinical obstacle. There was a troponin I analyzer at the South Health campus that was brought in and validated to be used in the Ebola outbreak in 2014. It was going to be used to assess myocardial involvement in hemorrhagic fever. However, this has never been used. Therefore, Dr. de Koning and his lab will be setting up this troponin I analyzer at the ACH as a screen only. The irony that another global infection has mobilized this resource is not lost on us. So how it will work. If a high sensitivity troponin is ordered stat at the Children's Hospital, a requisition for 2 tubes of blood will be printed for the nurses. This will be then received at the lab. The one will be couriered over to the Foothills to have the high sensitivity troponin assay. The second tube of blood will be run concomitantly at the Alberta Children's Hospital with the Troponin I analyzer. This assay, which is different, unfortunately, than the high sensitivity troponin, so this is a conventional troponin I, is a point of care test on whole blood, and it should be interpreted as binary, positive or negative. Again, it's not comparable to the high sensitivity troponin T or I. This conventional troponin is not as sensitive and missed about 20% of low positive results. It is, however, quite specific. Therefore, if you do have a positive, you know there's cardiac involvement or cardiac myocyte damage. If it is negative and your clinical suspicion is high, you must wait for the high sensitivity troponin. There will be a report with each of these assays explaining this change and how to interpret both of the assays. But the bottom line is, when you're checking your patient's labs, ensure you know which assay you are interpreting. In the last week, Dr. Lawrence DeConing and the ACH lab have been approved to get a high sensitivity troponin I instrument. This is the same instrument that the urgent care centers are using. Although we don't have a timeline for when this will be implemented, eventually this solution will replace the conventional troponin I assay that will be implemented imminently. This is a reference of the 3 troponin assays that we will potentially be exposed to temporarily at the Children's Hospital. I will disseminate this information to the group as a guide on how to interpret these results. All of these reference ranges are in acute myocardial infarction and therefore will potentially differ in the pediatric population. We still don't have a good cutoff that is well validated in the literature, and so all of these tests need to be used with caution. In summary, for ACH providers, a cardiac troponin I is coming. It will only be helpful in making earlier diagnosis and help with our potential dispositions and planning if positive. If you're in doubt of which troponin you're looking at, use a reference. Lastly, if you're experiencing a delay in the high sensitivity troponin, please do not call the lab. The lab doesn't actually handle the transport of specimens. Instead, if you're not getting in the lab, if the lab has not come back within 90 minutes, call accessioning with the number here, 57390. Dr. DeConing has been working with them and have told them to use a cab if they are not accessing a stat courier. Dr. DeConing has given us the go-ahead to politely remind them of this if they haven't been dispatched in a timely manner. I'd like to finish this talk by discussing some important management steps in patients with myocarditis. We are going to treat this patient like any other sick patient in our department. If they require intubation, ensure that you're resuscitating them before intubating. If intubation is required, consider using more of a cardioprotective intubation and be very mindful of your induction agents. I would potentially be reaching for midazolam or fentanyl, or combination, as this is one of the times I wouldn't be comfortable, or I'd be less comfortable in using ketamine. These patients may be on the brink of cardiovascular collapse and be catecholamine deplete. And as we know, ketamine could worsen this. Use a judicious amount of fluid if you're concerned about cardiac pathology, starting with a 10 cc per kilo bolus. Ensure that you're sending a broad spectrum of labs, including a troponin, VBG, and getting your ECG and chest x-ray as soon as possible. With like any other sick patient, consider early empiric antibiotics if there's diagnostic uncertainty, which there often is. If these patients do require an ionotrope, I keep it simple and reach for epinephrine first at the Children's Hospital. At the Children's Hospital, it is the vasopressor that our team is the most familiar with. And lastly, make sure you're calling for help early. PICU and cardiology can help arrange a stat echo. And remember that these patients may require ongoing aggressive ventricular support, including ECMO, and may require, in the future, a VAD or cardiac transplant. To make this diagnosis, to summarize all of this, to make this diagnosis, you need to maintain a high degree of suspicion for this diagnosis. Remember the different ways in which it can present. It could be fulminantly, like Penelope, who first presented with lethargy, fussiness, and tachypnea, bilateral lung infiltrates despite no cough or infectious symptoms, then progressed to full-on cardiogenic shock. It could be similar to an acute MI, like Matt, who had a localizing ECG and high troponin. Phone the cardiologist and potentially the cath lab to help decipher these patients. Patients could also present with subtle ECG changes, arrhythmias, or unexplained syncope, just like Jeremy. Scrutinize your ECG for clues and add your troponin and chest x-ray if you're worried. And lastly, know that this diagnosis is still very non-specific. Think about it in your younger patients with work of breathing and tachypnea, in your teenagers with chest pain or palpitations, and in any patient with unexplained vital signs or repeat presentations. Initiate a workup with ECG, chest x-ray, and a troponin. Remember that in children less than 1, they're going to have a high sensitivity troponin that is elevated at baseline. So interpret these results with caution and perhaps phoning a friend. Lastly, for our colleagues at the Alberta Children's Hospital, know that we are getting an in-house troponin eye assay very soon, so be ready for it. This is in no way replacing the high sensitivity troponin that we will be sending over to the foothills. So with that, I hope you've learned something, even if it is just in fact a newfound algorithm to find Waldo. You can impress or humiliate your friends and family. And I'm going to turn it over to Dr. Jen Graham to help me answer some of these questions.
Thanks, Katie. That was great. We've had someone who was asking what assay, but I think you've really covered that well. But I think Dr. de Koning wanted to make a quick comment about turnaround times.
Yeah, that'd be great.
Hi, can you hear me? Can you see me?
Yeah.
Yeah, just a comment about the 21%. So actually, that refers to our stat requests. So we get about 1 troponin request a day, but that includes routines. 2/3 of those requests are stat, and 1/3 of, or 20% to 1/3 of the stats are over 120 minutes. And incidentally, those are the ones that we got the RLSs filed upon because it was affecting patient care.
Okay, thank you.
And more about the assays. So the instrument that we brought over from South Health Campus, it's actually a point of care testing instrument by Quidel. It tests for normal sensitivity troponin I. We can run it on whole blood, but it has to be a lavender top tube. And that test will be run alongside the high sensitivity troponin T test for stat and time critical requests. The idea is that that result will come first, so we get that faster turnaround time. If it's positive, strong suggestion of myocardial involvement, but if it's negative, you have to wait for the troponin T. So really what you're getting when you order stat and time critical troponin at the children's site, you're getting 2 tests done. You're getting the high sensitivity T at Foothills, and you're getting the regular sensitivity troponin I at Children's. This is the best we could do given our resources at this time. The better solution is to get the high sensitivity test on site. I've been assured by our executive at Alberta Precision Labs that will be receiving a Biomuriu Mini Vitus, that's the instrument, that runs high sensitivity troponin I probably in the next month, and then we'll have to work it up and probably go live in a couple months. So obviously this will solve the problem of having high sensitivity at high speed at Children's, and it will also give us similar tests that the adults have access to. And this is pretty important, I think, right now with COVID-19, where we may have adult patients coming to this site.
Thank you, Dr. de Koning. That's very helpful. And just to emphasize, this is not replacing anything that's done already. It's adding on top of what we can do for these patients. just going through the questions right now. Dr. Betzner had said fentanyl and midazolam combined are way more hemodynamically challenging than judicious ketamine and cardiogenic shock in his experience, which is very helpful. Fentanyl by itself is a very stable induction agent, so perhaps consider that if you're not using ketamine and cardiogenic shock. And I think this is a very good point, well taken. I've discussed with a few of the PICU colleagues, and again, there's many ways to safely intubate these patients. I don't have a ton of experience. I've been involved in one intubation with just using fentanyl as an induction agent, which was quite successful. So I do agree with Dr. Betzner with that. And adding midaz, I guess we're less comfortable with. So perhaps it's more of the textbook answer, but I would be more comfortable with just using a fentanyl induction agent for patients that are potentially hemodynamically unstable. And in terms of some of the answered questions, Dr. Betzner had also said that kids can get spontaneous coronary artery dissections and thromboses just like adults. Would seem to me the safer to cath once and then go down another route. I think this is a very good point, and this is what I was super uncomfortable with when I first saw that patient. And in discussing with Dr. Greenway, it's not a bad approach at all. And right, it's our practice is often demarcated with the patients that we see the most of. And so Dr. Greenway's population is very different in that he's seen children with myocarditis and perimyocarditis. And then at the adult sites, we're seeing a lot more coronary artery disease. And yes, children can get coronary artery disease or spontaneous dissections. And so I think my biggest take home is not that that patient shouldn't have gone to the cath lab, but a discussion needs to be made. And if there's concerns, they need to be brought up, and getting many players on board at the same time. But I thought it was a really excellent case just to highlight that your location is often your destiny in how these patients are treated. And that's not necessarily a bad thing, but just highlighting different management courses at the different hospitals. Dr. Peggy Thompson had asked, should we be instructing the nurses on which tubes to draw lavender for screening? Is there a specific tube that we should be drawn to send to the Foothills Hospital?
I can answer that.
Yeah, perfect.
Yeah, so the lavender top tube is not required for the high sensitivity T assay that's currently at all the acute care sites. We can of course run high sensitivity troponin T on it, but it's not required. It will be required for the screening test at children's only, and that instruction will go out in a memo. Please don't share anything yet about this because the test is not live, and I don't want any confusion about specimen types. I don't want to disturb the status quo. So yeah, basically at this point, status quo in terms of specimen requirements, but at children's, there will be an added requirement of a separate lavender top tube to get that screening test with the stat request, but not yet.
Thank you. Dr. Gilliland from the ICU, thank you for tuning in, has said that his experience with acquired coronary artery disease, which is the most common pathology being from Kawasaki's disease in children, that coronary artery disease that's not secondary to Kawasaki's is that it's very uncommon. He's personally seen more pediatric patients harmed by well-meaning providers in adult facilities sending to cath lab and having unrecognized myocarditis arresting. So again, this just highlights that depending on your population, and Dr. Gilliland is a PICU provider, it's very helpful to get lots of minds on board when dealing with these patients, and there's not one right answer, and I think that's very helpful insight. Dr. Yeah.
Sorry, I just wanted, because it's in the same topic, that Kim Myers on the comment section just wrote that coronary artery disease is not a pediatric disease, and that we tend only to see thrombosis of coronary arteries in our Kawasaki disease patients with giant aneurysms. And those patients receive fibrinolysis in our PICU, but do not go to the cath lab.
Perfect. I think that is very helpful. I'm just reading through the comments here. And then also from Dr. Myers, spontaneous coronary artery disease is not a pediatric disease. We tend to only see thrombosis of coronary arteries in our Kawasaki's disease, so exactly what Jen was just saying. Dr. Francis was saying, hopefully there'll be a note with the troponin I result indicating that if it is negative, clinical decision-making should await the report of the high sensitivity troponin. And Dr. Troponin emphatically has said that yes, they're definitely well, and that the wording right now is being reviewed by Peds Cardiology, Inpatient Pediatrics, and the Emergency Department, which just states exactly that.
Yeah, it's actually been finalized and submitted for our IT build. And so basically it states what we've already been discussing, that if positive suggests myocardial involvement, but if negative, we can't rule it out. So you have to wait for the high sensitivity T. It also incorporates a legacy statement about the performance of the assay and that it's a little bit more variable than what we're used to with troponin, but it's not high sensitivity. So I think if we all are aware that it's not high sensitivity, we probably won't realize that it's not as stable either. So, but it does give good positivity rate in general.
And Dr. Ambrose had just asked an excellent question. Will high sensitivity troponin I, which is kind of the next step, be adequate for cardiology at the ACH? As she's seen some patients that sent in from urgent care by the cardiologist or the adult cardiologist's advice solely for the high sensitivity troponin. And Dr. Cronin had answered that. Do you want to just quickly note on that?
So regarding the discrepancies, we've seen them both ways. And I realize there have been some consults for troponin I when TNTs haven't been believed either. So we're hoping that it will be adequate in the long term. I will say that another goal of this project is to develop pediatric reference intervals for TNT and TNI in Calgary. And we can use the CALPER project to do that. So that's on our hit list of things to do once we get the instrument put in place.
And just this is a quick case that highlights the discrepancy in the high sensitivity troponin T and I. This quickly was a 14-year-old girl that actually presented to the periphery with some URTI symptoms that were resolving, some chest pain. Initially was quite unstable tachycardic and tachycardic and hypotensive. And was managed very appropriately by our outpatient or by the urgent care colleagues with starting fluid epi infusion. Her high sensitivity troponin I was 3,400, whereas her high sensitivity troponin T was only 378. So it's just what it's highlighting is that these assays are different and they're looking for different molecules, and so we can't compare them, and it's hard to know exactly what the best test is for these patients. So Dr. Doshi had said, given the number of chest pain presentations we see and the variability of presentations for myocarditis, with normal vital signs, normal ECG, normal chest x-ray, but persistent chest pain, would you suggest a troponin in these patients or more of a return to emergency department process if feeling worse? So I think this is a really good question, and this has been borrowed a little bit in the literature. And again, it really comes down to a lot of things in pediatrics is your clinical judgment, which is sort of a cop-out answer. But specifically, there was a study that was done out of Atlanta looking at patients where chest pain was done, or chest pain was a presentation and a troponin was ordered. And myocarditis was found in a significant portion of those patients, but knowing that there's bias in who you're going to actually test for a troponin. And so my thought is that if they're having persistent chest pain, I think that we test for far less, and we do white counts on people for far less, and it's a highly sensitive test, and I think it can provide some reassurance. But knowing that if they're coming in with 12 hours of chest pain, that I'm not necessarily doing routine troponins on each of my pediatric chest pain patients. So long story short, not necessarily, but depends on clinical circumstance. So And okay, and then I'm just one last comment from Dr. Greenway here. The cutoff of 100 nanograms per liter for high sensitivity troponin is arbitrary and should be used in the context of the clinical situation, and suggesting peds cardiology consultation if concerned. And I think this is a huge and a great place to end. A big takeaway is involving our pediatric cardiology colleagues in these discussions, and they can help us with the management and disposition planning of these patients. So with that, I think I'll end there and hand it back to our hand it back to Erin Peterson and then the COVID group. I hope you guys have had a chance to actually find Waldo and have a good rest of the day. Thank you.